she told me, you can do whatever you want to do. Don't let anybody tell you otherwise. From the second that you get that white coat and you say the Hippocratic Oath the first time you're called doctor is just very, just life-changing. I just look at it as I am a spine doctor, and I just want to explain their pathology to them on a level that they can understand, and then help them get better.
Today I'm speaking with Dr. Betsy Grunch. Dr. Grunch was born and raised in Gainesville, Georgia. She graduated from West Hall High School and went to the University of Georgia, where she completed her Bachelor of Science degree in biology. She then went on to medical school at the Medical College of Georgia in Augusta, Georgia. She matched in neurological surgery at Duke University and completed her internship in 2008. She trained in neurological surgery at Duke University and graduated in 2013. At Duke, she earned the Synthes Spine Fellowship from 2010 to 2011. Dr. Grunch's main interests are minimally invasive spine techniques and advancing the field of neurotrauma. She lives with her husband, 2 children, and her 2 dogs in Gainesville, Georgia, and she is board certified by the American Board of Neurological Surgery. And an interesting statistic that I learned, Dr. Grunch, is that only 5% of board certified neurosurgeons are women. So you are definitely part of a select group. Really appreciate you joining me this morning, and looking forward to speaking with you.
Yes, sir.
So why don't we go back to the beginning? Maybe when you were younger in high school, or what led you to become interested in medicine and ultimately pursue a career in neurosurgery?
Yeah, great question. So actually, I was probably like most little girls and wanted to be just like their mom. My mom was a police officer actually here in the town where I grew up, in the town that I'm at. And so I always thought that was just so cool, and I always admired her. And so I thought actually I was going to be a cop. So when I was 13, she was involved in an on-the-job accident. She was suffered a C4 spinal cord injury and was paralyzed from the neck down. At that time, it was about 2 weeks before I was starting high school, 9th grade. So a very pivotal point in a kid's life. So that was very devastating to our whole family. So she went to the Shepherd Center for Rehab, one of the world's best rehab centers, and just that whole experience being with her and having her home. I just wanted to learn how I could fix this, because it was unacceptable to me that was just how it was going to be. So I actually trained to be a certified nursing assistant when I was in high school, so I could take care of her, and started shadowing her neurosurgeon here in town, who's actually my partner now. Wow. It just, wanted to learn about the spine, the spinal cord, and how something like that could be so devastating. So I decided in high school that I was going to be a doctor. I was going to cure spinal cord injury. And so that's how I got introduced to medicine.
That is crazy, and I'm so sorry that you had to go through something like that. I can't imagine, going into high school, and certainly you had to forego a lot of things to take care of your mom, I'm sure, and I'm sure she's really grateful, for a daughter like you. How is she? What's your mom's name?
Betty.
Betty. How is she doing? How's she doing today?
She's good. That was in 94. So it's been 20 something years.
That's crazy.
Yeah. And she's still, she never gained any neurological function back, but she's doing okay. She actually lives a mile from me. So it's kind of nice being able to be so close to family. So.
Yeah.
Yeah.
Man, do you think, there will ever be a day where, neurotrauma, neurosurgery, will be able to reverse injuries like that? Where's the research at now with things like that?
Yeah. I think that we've gotten better. I mean, we definitely know things that back then maybe we didn't know. I think curing traumatic spinal cord injury may never be achievable, but I mean, once you have a damage there that's so catastrophic, I mean, sometimes it's beyond recovery, but I think we do know things with minor injuries, or with even some moderate spinal cord injury about timing of surgery, about medications, about adjuvant therapies that I think that definitely help people. And I've seen people that I've taken care of that come in, very neurologically devastated and regained almost complete function back. So I think we've made a lot of progress. Would it have helped someone like her? I don't know, but we'll just keep trying, I guess.
Yeah.
Keep pushing forward.
So why is that? Because if you tear your Achilles or your ACL, you're able to, harvest and put another ligament in there. So what, obviously the spinal cord is different. Why is it that you can't, kind of reestablish those connections?
Yeah. The nerves are just, they're just delicate. It's kind of like a brain stroke too. Same concept, when you have such an injury to the neurons that make everything work. I mean, they can't regain. I mean, sometimes with traumatic peripheral nerve injuries, you can graft nerves back and regain function. It takes a long time just because nerves just don't heal like any other portion of our body. But with central nervous injuries, it's a challenge, and oftentimes, the damage is done from the time of the injury. But I think we definitely have learned a lot about how we can minimize secondary injury and other things like that will improve function. So, even someone like her with she's a C4 injury, if you could preserve that C4, C5 segment, that would give her much more use of her arms than if you had secondary injury went all the way up to C3, it'd make her trach dependent. So I think that, minor things that we can do to help to make pretty big differences. So
yeah, it's interesting. Last night I was watching just randomly that movie $1 Million Baby. Have you seen that? Yeah. So
it's been a long time. Yeah,
it's been a long time for me too, and I just came across it and started watching it. And yeah, her in the movie, her injury was C1, C2, and so that's a big difference. Just so it's crazy, and hopefully you don't take this the wrong way, but even there's always something to be grateful for, as terrible as your mom's accident was, it's
hard to see it that way sometimes, but I think definitely there you would always look at things that you can be grateful for. And, she's still here, although she's battled a lot of challenges from a mental health perspective. Sometimes she wishes she wasn't here, but I think that even goes for normal functional people. And, I think we just live our life the best we can. And one of the things I've learned from being just a trauma physician and taking trauma calls, you just never know. You just never know what will happen to you. And just got to be grateful for every moment you have with your family, with your kids, with the ones you like to be around, and just be grateful and enjoy life, because you just never know.
Yeah, absolutely. So speaking of kids, I have 3 daughters, a son, and then there's, I think, 4 or 5 women that I work with. So I have a lot of women in my life. My dog's a female. And when I was looking up the percentage of women that are board certified neurosurgeons, it was really shocking to me that only 5% are female, which is, it's crazy, because I look back to high school and college, and I swear all the valedictorians and all the top of the class were women. So I just, it's really interesting to me. So I guess as a woman, what advice do you have for younger women out there going into medicine, and maybe even those that are, looking at neurosurgery? What was your experience like, and what advice would you give to them?
Yeah, I think a lot of it is around who you're around and what role models you have, and kind of your support system. And I just never had anyone that told me that I couldn't do anything. And like my mom, for example, I mean, she was in a very unique profession at the time, in like in the early '90s. Like there wasn't many female cops either. And she was actually like on the dive team, and she was a dispatcher too. So she just did a lot of things that was in a male dominated field. And she told me, you can do whatever you want to do. Don't let anybody tell you otherwise. And so I think, I actually want to be a professional baseball player. That's what I wanted to be when I was little. But
that's how my daughter is. She's 7 right now, and I'm like, "Do you want to do softball?" She's like, "Nope, baseball."
Yeah. That's where I was. So I think just learning, and having that support system that where you don't feel like you can't do things is just so powerful growing up for young girls. And that's where I was at. And I never, like, the physician I shadowed in high school, all my professors in college and role models, they were all guys, because like you said, there's not a lot of women in neurosurgery. So, and none of them, I mean, there may be a time or two where people said stuff to me, but none of them ever discouraged me. And I think even in my training, like I was one of, I think, 3 women there in the entire training program. And it was, I mean, I never felt discriminated or otherwise. So I just think, you just got to have that mindset that you can do things that anybody else can. So that's it. Yeah.
Yeah, no doubt. I heard this last week. I forget, it was another physician, I forget who, but it was a physician that told me, he asked me, he said, "You know why men are physically stronger than women, don't you?" And I said, "No, why?" And he goes, "Well, because if women were physically stronger than men, then they would really rule the universe." So I thought that was pretty funny.
That is, yeah.
There are definitely women out there that are stronger than me, though. So I don't want to say all men are stronger. What was your, maybe back in medical school or right, coming out, what was your first experience you remember when you're like, "Oh, wow, this is amazing. I'm really proud to be a doctor as I was able to, help this person." What was one of those first moments you remember?
I mean, I think, from the second that you get that white coat and you say the Hippocratic Oath the first time and you're called doctor, is just very, like, just life-changing. But I think there's just so many moments along the way that you just feel, grateful for getting a position that you're in. But I can't remember the first time where as a doctor, I think being in residency, there was a patient that came in as a trauma, and we took them to the OR and saved their life. And the family was so grateful. And in those kind of situations, they don't know if you're a resident or if you're an attending, and those patients are always so grateful. So it was actually a teenager and had an acute subdural, and we saved their life and walked out of the hospital. I mean, came in almost dead. So those are just moments where it's like, wow, this is cool.
That's crazy. Yeah, that I can't imagine, I just being a small part as a, medical device rep, being around some of the things that neurosurgeons like yourself do is just totally incredible, and I really enjoy it. So, looking at your training, your CV is obviously very impressive. You trained at Duke, and I guess Duke's obviously a world-renowned program. What was it like getting into Duke and being part of the history there?
Yeah, it was awesome. I mean, I knew I wanted to stay in the South just because I don't do well in cold weather. So I wanted to stay kind of close to my family, and being from Atlanta, I did all my training, high school, obviously, but college and medical school pretty close. So I wanted to stay somewhere in the Southeast, and I felt that Duke had a very comprehensive program, and obviously spine was really important to me. I love neurosurgery, but I really wanted to focus on spine going in. So I felt like they had a great program there. And when I went, when you go somewhere, you interview at places, jobs or whatever, you'll have that feeling like, okay, this, I can fit in here, or you don't. So when you go on these interviews for residency, it's the same thing. And I just felt like everything clicked, and I was just grateful that I was selected to go there. So it was very, very rewarding. And the chairman there, who is still there, just so supportive. And so just a very, caring person for residents. And I'm just grateful that I got to do my training there and provide all that knowledge to the community here. So
yeah, no, that's great. Looking back, was there anything when you were interviewing or trying to match for your residency, looking back, any advice you have for any of the younger surgeons matching, things you wish you would have done or known back then?
Yeah, I mean, that whole experience is just kind of a whirlwind. It's intimidating because you're talking to, all these neurosurgeons and trying to explain why you should be selected. It's kind of daunting, but you have to also put it in your seat as to, okay, well, this is assuming that you have the qualifications and that kind of stuff. But this is my decision. I have to fit in. I have to find a place where I'm going to succeed. And unfortunately, a lot of people match at places where maybe they don't fit in, or maybe it's not the best. I mean, just because you want to go to X, Y, and Z program because it's maybe the world's most renowned or whatever. I mean, it's really, you've got to spend a large majority of your young adult life in a place where you'll be happy personally and professionally, and that's really the key. And that's really what I try to look at in life in general, is trying to, it's not always about the best. It's about, what's best for you. So.
Mm-hmm. No, that's so true. I think that, yeah, absolutely. So you've been in private practice going on 7 years now. Is that right?
Yeah, 8. Yep.
8 years. What can you tell me about your practice and the hospitals that you operate out of? So I actually came back to my hometown that I grew up in. I mentioned I live like a mile from my mom, and that's not because she moved to me. It's because I moved here. So I, found a practice here where I knew the surgeons and obviously wanted to serve the community that I grew up in. And so I'm at Longstreet Clinic, which is a multi-specialty private practice. And I'm with a group of 5 other surgeons, including Dr. Mahana, who is the surgeon who operated on my mom 20-something years ago. So kind of come full circle. But I practice at, we operate out of Northeast Georgia Medical System Medical Center, which has several other neighboring facilities. But I work there, and really grateful just to be able to serve this community that really raised me, so to speak. So it's great. I don't see myself ever leaving for any reason. Very, very happy with the medical community here and my role here. So yeah, it's amazing. Gainesville is pretty close to Atlanta, right? About
yes,
an hour or so, 45 minutes. It's pretty crazy to think about, where you grew up, going back and being a practicing neurosurgeon. That's pretty rare, honestly.
Yeah, I mean, a lot of new doctors pick jobs and don't know, kind of what they're getting themselves into. And I think I've just been lucky to have made those right decisions and be happy. Like I said, not just in my job, but in my life and raising my family. So it's been great.
Mm-hmm. What's the hospital like that you work out of in terms of, the equipment and technologies that they, provide you as a neurosurgeon? What, kind of what's their setup?
Sure. So our main campus is really the place where I worked most in Gainesville, and they have grown tremendously. Even in the time that I've been here, we've gone from just non-level trauma center to now level 2 and maybe even a level 1 trauma center. They have GME here, meaning that they have residents that train here now in the past few years, which is mind-blowing to me to think, when I was in high school, this small hospital that's grown into basically this mega center. And yeah, so I mean, obviously they have made efforts to be the best in the area, and that's on all fronts, and very, supportive of our neuroscience program. We have intraoperative navigation, and, top of the line technology, and anything that I have been a proponent of from a perspective of advancing the field or cutting edge technology. They've let me experience that, so it's been great.
That's great. Are you so the main campus you operate out of? Are there any outpatient surgical facilities that you operate out of as well?
Yes. So Northeast Georgia Medical Center, Gainesville is like I said, the main campus, I guess, the big house. And then there's a Brazelton location, which is a smaller satellite location that I operate out of. And then there's an outpatient surgery center. It's called Gainesville Surgery Center. And that's where I do my ambulatory surgeries.
And what's the, I guess, progression been like over the last few years? At least, where I'm from, I'm seeing a lot of physicians starting to take their spine patients to ambulatory surgery centers. Is that something that you're doing as well?
Absolutely. Yeah, I think, again, when like 7 years ago when I came here, all I did at the ambulatory surgery center was carpal tunnels. And then, I think insurance companies and physicians and patients, it makes sense to do a surgery that can be done in an ambulatory setting in that type of setting, because it saves costs, it saves, now in the COVID era, it saves hospital beds, it saves hospital resources, it saves, exposure to patients to things that you see in the hospital. So I really think it's been a driving force over the past few years, and even in the past year or so with COVID, really pushing surgeries that don't need to be done in the hospital setting to an ambulatory setting just makes sense. Mm-hmm. So
safer, less expensive, it makes sense. Correct. For everyone, right?
Absolutely. And luckily I've been blessed, but I mean that we've had no experience where I regret saying, I should have done this at the hospital. I mean, you have to obviously kind of look at the patient and make sure that that's the right setting for them. But I think it'll continue to push in that direction in the future too.
Yeah. As a patient, a lot of people, just going to a doctor can be really intimidating. And I think for a lot of people, if you're told that you need to go see a neurosurgeon, that can be even more intimidating. How do you make patients feel at ease when they come and see you?
Yeah, I think that's a very true point, and I think that's where a lot of physicians maybe have trouble. But I think you just have to kind of look at patients as a person, or as your friend, or as your parent, or as your brother, and like they don't understand words that you're trying to explain to them, and really just I kind of try to get. I think some of my experiences has helped me do that, but really trying to, all they want to know for the most part is what's wrong with their back. Why does my back hurt? Why does my neck hurt? And a lot of times that's all they want to know. They don't necessarily want surgery. So I don't consider, when I open the door and go see a patient, I don't think, oh, okay, this is my next case. I mean, really, I think patients, I just look at it as I am a spine doctor, and I just want to explain their pathology to them on a level that they can understand, and then help them get better. And if that is surgery, awesome. If it's just some physical therapy, great. I mean, you're still success patient by patient by helping them with their quality of life. And really, spine pain is from, I've experienced it too. It can be quite devastating to someone's life and really interfere with anything they do from the time they sit up in the morning in the bed to the time they lay down at night. So, it's not like an arm injury where maybe you could just not use that arm. I mean, you use your back and your neck all the time. So I think really trying to, just make sure that you're explaining things on a simple fashion, in an understandable fashion, but also just relate to where they're at. And not every back's the same. So you have, some patients with horrible looking spines and they look fine. And then you have some patients with teeny tiny little disc tear and they're devastated with back pain. And patients' perception of pain can be so vast across the board that I try not to judge as to like, oh, well, this person shouldn't be hurting that bad. And if you treat someone like that, you're going to lose them as a patient because you have to really understand and relate as to why they're experiencing the pain. And I think that's where a lot of people can be successful. So,
looking at your website, you have a lot of great resources on there. So nice job with that.
I need to make it better.
Nah, it's good. Is there anything patients can do maybe prior to seeing you that would help them prepare for their visit with you?
Yeah, that's a good question. I think a lot of patients don't understand their pain or how to explain their pain, which can be very important to a spine surgeon as to making decisions. Because the spine is complex, and there's so many portions of the back that can be pain generators. And I think patients are just like, oh, my back hurts. Well, okay, well, where, how, when, what makes it better, what makes it worse? What distribution do you really feel it in your arm or your leg? And trying to find out what I can do to help them is really dependent on how well they can explain their pain. And I think a lot of patients don't really think about it that way. They just think they can come in and just kind of say, well, it hurts. So I try to encourage patients to really, have a whole questionnaire that I have them fill out, and some people do a great job at it, and that's helpful for us. So I think that, and obviously, bringing everything to their visit is helpful, MRIs, imaging, and that kind of thing. But just being prepared to really try to explain what makes it better and what makes it worse is helpful for us.
Mm-hmm. No, that's interesting. I never actually thought of it that way, but that makes complete sense. Just being able to explain in detail what they're going through, because then you can kind of navigate to exactly what's going on.
Yeah, because it's like, you'll have a patient with maybe someone in their 60s and have terrible scoliosis. And, maybe they're one of these patients that can really they tolerate back pain pretty well. But maybe what's given them problems the most part is their, pinched L4 nerve from their curvature. And if they just say their back hurts, and I'm thinking, oh, shoot, maybe they need a deformity correction, but you really narrow in on it and understand that, well, my back hurts, but every time I stand up and walk, I get this shooting pain down my buttock and down to my knee. And so trying to really narrow that down, because maybe all I need is a foraminotomy, an outpatient 45-minute procedure, and reduce, their pain by 80%. And they don't need deformity surgery. So I think, really trying to tease out that is helpful for surgeons, because, T10 to pelvis for me is fine, but recovering from a patient perspective is very life-changing.
Yeah,
so.
Absolutely. So obviously you have a focus in minimally invasive spine. Can you talk a little bit about the type of procedures you offer patients?
Yeah, I think to be a successful spine surgeon, you kind of really have to understand everything in spine and all the different approaches. And there are so many things that you can do, from endoscopic pin, poke incision to Spinology technology to, open deformity correction and anterior approaches, lateral, posterior. So I think, having all those tools in your belt and really understanding the success of each procedure and what they bring to the table, and also really looking at the patient and deciding, well, maybe in this 82-year-old person with scoliosis, they don't need something like that. They need something more minimally invasive, because they they won't, that will wreck them if they have to go through that type of recovery with the complications that come with that. So I think just having an arsenal of approaches and understanding the complications associated with them and the success is really where a successful spine surgeon will succeed the most.
So you and I originally met at a recent Spinology training course where you were the proctor for the new optilift procedure. I'd like to talk a little bit about that procedure and your experience. I guess, first off, what would you maybe say to a peer or one of your colleagues that are maybe looking at optilift, considering incorporating it into their practice?
Yeah. So it's such a different technology, and it's so it's just different from the traditional cage that we've all been taught. And I'll be honest, my partner, Dr. Schultz, he's the one that made me even look into the optimesh implant, because he actually implanted the first optimesh in the entire United States years ago. So he's an avid user of the optilift and optimesh and a variety of techniques. So I was like, well, I'm not putting a bag of bone. I mean, that doesn't make sense. I need a cage. I need a metal cage to hold it open, blah, blah, blah. And then, as if you really think about it and how the technology works, yeah, it's minimally invasive, but it conforms to the end plates. And you look at all this technology that's out there now about 3D printed custom implants, and that's essentially what optimesh is. You place it into the disc space, and it conforms to all the natural convexities, concavities of the patient's inner space, and provides indirect decompression like an expandable cage. And I think once someone can kind of overcome that thought process of just how structurally it works, it's a very strong implant that they, then they can really adopt into their practice. So I decided I would give it a try when I've been practicing for several years. Dr. Schultz didn't say, oh, you need to use this implant. I mean, I just knew he was using the technology. I've seen his patients for second opinions or in the hospital. I've seen complications of my own and other surgeons that don't use the optimesh. And I could never think of one that I saw that had, a non-union or a problem with the implant in comparison to the magnitude of other pseudoarthrosis or failures or subsidence or, what have you. So yeah, I think, and then of course, being able to place it percutaneously is just game changer. So
that's interesting. So really kind of a combination of seeing Dr. Schultz's outcomes, and then maybe you weren't as excited about some of the interbody implants that you were using. That sounds like to me that's what kind of was the tipping point for you to start looking at optimesh.
I thought I'd try it. I mean, he used to place them in a more open traditional T-lift, which you can fashion. But, when you get in and do a T-lift, I mean, you'll find that sometimes it's so hard to retract the nerve. You'll have radiculitis after surgery from trying to put in this huge implant in. And then sometimes you'll skimp away by trying to get a skinnier implant in. But then there's, risks that come along with this smaller implant. So this is an implant that you can put in through just a 7 millimeter access point to the disc that expands to essentially almost the majority of the disc space. So it it just makes sense. So I decided, okay, well, I'll try it. I'll do it on a few cases. And as I did them, I'm like, wow, this is pretty cool. So yeah, there you go.
Have you noticed, kind of looking back before you used the optimesh implant to now while you're using, have you noticed a difference in outcomes for patients?
Yeah, absolutely. So, I mean, for me personally, how I adopt optimesh or optilift into my practice is, I mean, I still do a ton of A-lifts. I still do some laterals, but essentially any T-lift or lateral that I've done, I use the optimesh. And so, you go from taking that where you have to take the facet down and expose the nerve roots, and from a T-lift perspective, or from a lateral perspective, the radiculitis or psoas retraction that you get, and plexus type issues with thigh pain and stuff, all that goes away with the optimesh. I mean, you decrease blood loss, CSF leak, all those things that that come along with placing a cage in those traditional fashions. You mitigate, and it's faster. So I can, as soon as I start my case, I'm going to start my inner body. Before I even open the skin, if I'm doing open, I can place inner body in, have the distraction in, and it's done in 20 minutes. So that's with no blood loss and no minimal nerve retraction, if any. So I think, from a pain perspective, it's better for the patients. Obviously, from a blood loss perspective, surgical time perspective, it's completely different. So if you have a surgeon, I think, that does like a lateral and then a perk, because they have all these new technologies. Well, we can do a prone lateral or an oblique lateral, or even I've had some surgeons at my facility that do a lateral and then perk screws from this while the patient's in a lateral position, which is challenging. And I don't know if it, I mean, obviously, if the surgeon is challenged, sometimes you can have misplaced screws and that kind of thing. But I mean, you can take a front back surgery and do it all prone in an hour. I mean, I can place perk screws in the inner body in an hour. It's just all the way around winner for surgeon and patient. So,
mm-hmm. Yeah, I think that's something I think about too, because I spent some time with invasive, 10 plus years ago when laterals were really becoming vogue. And, I think about it now, just everything that you said, certainly there's patients that need an A-lift or perhaps a lateral, right. But for, all things equal, to me, optilift makes a ton of sense because of the reasons you said. You're not retracting the psoas, you're not, taking down the facet and, potential issues with CSF leaks and all of that stuff. So I completely agree with you. Mm-hmm. That being said, optilift, the approach is, at least the percutaneous approach is maybe something new that a lot of surgeons maybe don't train on, that transcambin approach. Mm-hmm. How did you become comfortable with the transcambin approach, and what advice would you have for surgeons kind of preparing to do that?
Yeah, it's like you said, I mean, you don't train on that approach. I never learned that approach at all. So it was super intimidating to do that. And no one trained me to do that. Now, we're taking surgeons out and doing cadaver labs and getting hands-on exposure, but no one taught me to do that. I just kind of looked up the approach because it wasn't, at the time I was using it off-label, but I just read up on the approach. I mean, it's the same kind of approach with an endoscopic. So it's a pretty easy adaptive concept to surgeons, that are used to doing endoscopic work. But for those that aren't, I mean, it's super easy. And I think once you do like 5 or 10, I mean, it's just, I mean, it's easy once you just kind of wrap your mind around the approach. And really, you're placing a probe safely into a space that is accessible, and you've got a nerve probe there. So if you are, close to something, you'll know immediately, and really without significant risk. I have never placed, even come close to placing something in the canal, because it's just not possible. Well, I won't say not possible. Anything's possible, but it's very difficult to do something dangerous by this approach. So,
yeah, and you mentioned that as a spine surgeon, neurosurgeon, being able to offer patients an arsenal of procedures is key. Obviously, optilift isn't for every patient. I guess what's sort of your algorithm or maybe cutoff where you say, these type of patients are optilift candidates, but maybe these ones are not. Maybe I should do an A-lift or something else.
Right. Yeah, I mean, there's several cases where maybe optilift isn't the best, and on 5.1 you can do an optilift with 5.1, but I prefer an A-lift just from my perspective because I've got a great access surgeon, and 5.1 is a little bit more intimidating to come into from an optilift perspective because of pelvis. There are some patients with very low riding pelvises that you can get into 5.1 very easily from an optilift, but those other ones, so typically in my hands, I do A-lifts at 5.1, and then any really significant spondies or a little bit of a challenge to access Camden's triangle just because of the slippage. It's not impossible. It's just maybe a little bit more challenging, and maybe an A-lift will be something there. And then on sagittal deformities, you probably need to release ALL and put in a hyperlordotic cage. So I'll use a lateral for that. But yeah, I mean, optilift is pretty universal, though. Even in a lot of those cases, is possible. Maybe not with ALL release, but one of my favorite applications of the optilift is on revision work. So like someone that's had a TLIF and has had a pseudo can come in from the opposite side and drop a bag right beside it, and that's super cool. Or maybe on someone with an instrumented fusion but no inner body, just dropping an inner body there can sometimes just really save the construct. So those are neat uses. I failed to mention too, just really thinking about the patient's prior surgery. I mean, unfortunately, in the spine world, reoperations are common, and I don't want to be accessing Cayman's triangle maybe on someone that's had a facetectomy or has had exposure scar tissue in that area. So trying to, if the patient's had like a right-sided foraminotomy, maybe a left-sided optimesh would be better. Mm-hmm. So,
yeah, that makes sense. You mentioned it's the optimesh implant is unlike any other implant out there, and some spine surgeons might not be familiar with it and how it differs from your traditional PEEK or titanium or custom manufactured. So in your experience, how does optimesh perform in restoring disc height, sagittal alignment, lordosis, and also I remember during the training talking a lot about post-operative imaging, what to look for, because it does look different on post-operative imaging. So can you speak on that?
Yeah. So, I mean, I think in terms of correction, it is a very powerful indirect distraction of the end plates. And I think since it disperses the forces in such a way that's kind of across the whole inner space, you get really nice, not only just rise of the disc space itself, but correction of deformities. If you think of the annulus as supporting the space as a whole, and if it's collapsed, when you put in the implant and expand it, it's going to naturally just rise to its native form, if you will. And that can be coronal shape. It can be, just rise itself, lordotic shape. So, I mean, you can be kind of fancy and if maybe the disc space is more coronally off on right side, and you can try to place the mesh more on the right side, or even direct all the bone graft when you're putting in the divertive tubes more to the right side, which is one technique that I use. You can really correct these deformities in a way that is very similar to lateral or T-lift or A-lift or whatever. And then same things with spondies. It'll when you distract the forces on the A-lift, it'll or on the optimesh, excuse me, it'll pull that spondee back pretty impressively. Now, you mentioned about the imaging. That's something that too is kind of the post-operative X-rays just look. It's not a cage, so it just looks like a shadow. So it's kind of different from looking at it from an X-ray perspective. But if you have surgeons that are big-time CAT scan surgeons, or post-op imaging, like in my practice, I do a lot of post-op imaging. I think it helps me understand how to be a better surgeon, but it also helps reassure the patient that if they're having some post-op symptoms, that I am interested in and trying to make sure everything's perfect. So I do a fair amount of CT imaging, and you will see, it's a cortical, it's a bone implant. It's an allograft implant. There's no structural form to it. So in the natural way, an allograft conforms and heals. You will have some osteolysis in the early stages while it's mineralizing. So you may see a little haloing around the bag. And that's totally normal. You're not going to see mineralizations till at least a year out. So, if you have somebody that does an implant and images in 3 months or 6 months and sees this haloing around the bag, they may just be like, well, this is not a great implant, but that's just the way it's going to look. So. Gotcha.
And then, optilift was just FDA approved less than a year ago. So now Spinology's come out with new and improved disc prep tools. Can you, because I've spoken with some surgeons about optilift, and they may have had some experience in the past with using it off label.
Yes.
But now I think the disc prep tools are really something that makes the procedure even better. Would you agree with that?
Yes, absolutely. The key to any fusion is achieving fusion. So if you have poor disc prep instruments, you may not get to that end goal in the best fashion. So disc prep is the key to any surgery. It doesn't matter what implant. You take any implant in the market and put it in a crappy disc prep, and you're not going to fuse. So yes, disc prep is important, and over the past 5 years, the disc prep instruments have dramatically changed, and then in the newest release, they're phenomenal. There's probably not an instrument in there that I don't use in some fashion just to try to assist in the prep, and really you're trying to carve out this big space through a small 7mm portal. So you've got to have kind of a variety of options in there to help you evacuate the disc. So I think they've definitely had a home run with the new set. So
nice. Couple more questions. I know you're on call, and I've already taken up too much of your time. So outside of optilift, you mentioned that you're doing navigation. What are some technologies that you're excited about incorporating, or something that you see coming down in the near future that you think will really help patients?
Sure. Navigation is a great asset to any surgeon's practice. I think intraoperative imaging too, like intraoperative CT imaging, is very helpful to me personally. Just making sure I'm a perfectionist, so making sure everything is perfect before I close. But those have all had their advances over the years. But I think even in the past few years, robotics coming into the spine space is really really fascinating, and trying to understand how we can make that better and safer is also going to be is going to be in the next 5 to 10 years in the spine world. It's going to be pretty common for most surgeons to be familiar with the robot. The worry I have with some of these technologies, though, is, in training and how that affects training, because you can't have a surgeon that's dependent on navigation, because you've got to have a bailout strategy. So I think in training programs, just the traditional approaches is going to be very important to try to maintain those basics too. Mm-hmm. So
yeah, it's fun. I was talking to one of the spine surgeons here locally a couple weeks ago, and actually about optilift and optilift is indirect decompression, and he's like, man, everybody's doing indirect decompression. I'm afraid a lot of surgeons are gonna lose the ability to do direct decompression. So to your point, that's interesting.
Yeah.
All right, so looking at medical device reps, in your experience, what separates maybe the good reps from the average or not so good reps?
I think, surgeons have a choice of what they, well, for the most part, some facilities make surgeons use certain implants, but to be a successful medical device rep, you really have to, not only get along with the surgeon, but try not to have implants that are going to make them successful. But just from a basic standpoint, you have to be prepared. So when I first came out, I just, basically tried everything because I wanted to know what was good in my hands. I experienced a variety of different sets and a variety of different reps. And, obviously there's personal interactions and people that you naturally gravitate to, which is sometimes outside of a control, but try not to be too pushy, but also really knowing where your products succeed and how to articulate that. And especially in spine, you have a surgeon that does TLIF. Well, what happens if, something we don't have, like if, I don't know, like the implant won't fit, or, having a plan B, particularly like, let's say lateral. Let's say you're planning to do a lateral and perk screws with the surgeon. They get in there and femoral nerves in the way. Can't use the lateral implant. Now they got to switch while the patient's asleep to a TLIF. You got to make sure that, you have that set available. If they ain't no TLIF set there, and you're kind of hosed. So I think that's where I've seen reps have the most success, are those that are really knowledgeable about, well, let's plan for worst case scenario. How can I be ready for that? Or maybe your trays are contaminated. You never know. And so you just kind of have to be ready for disaster and how you're going to handle that, and preparation for the case too. I really appreciate, my reps that I have just a small set now because my trust circle is small, but that we come in, we talk about the cases a week in advance. We know what we're getting into. We know what drivers we need to remove, the screws from the revision case or whatever. So those are all important things I think that a surgeon looks at. So.
Yeah, it's funny. I've asked a number of surgeons that question, and it kind of comes back to those two things. Knowing where your product works and fits, and having a plan B. I think it's it's simple in concept, but hard in implementation. It takes work and effort for sure. Well, Dr. Grunch, I appreciate your time. I guess one last question. You're a Georgia Bulldog, so who's your all-time favorite Georgia Bulldog?
Oh man, well, Herschel Walker is every Georgia Bulldog's favorite, but I think outside of him, I really loved Todd Gurley. He is one of my favorite running backs of all time. So. And he was with the Falcons last year. I was super excited. He came back home. And I don't know what's going to happen this year, but yeah. I've even got I don't have it. It's in my office. I have a autographed football from him that says, "As Dr. Grunch keeps saving lives," from Todd Gurley.